Welcome to the BioSalsa podcast, where we host community conversations on the biomedical industry in San Antonio. This $44 billion industry is the largest in San Antonio, the seventh largest city in the U.S. This podcast is brought to you by Medcial, a member-driven nonprofit with the mission to accelerate the growth of the healthcare and bioscience sector in San Antonio and the surrounding region. I'm Heather Hansen, president of Medcial. We'll explain more about Medcial and how you can access the biomedical ecosystem in San Antonio at the end of the podcast.
Hello, everybody. It is so nice to have the opportunity to speak with you today from Texas State University. My name is Dr. Rodney E. Rohde. I'm a Regents Professor and Chair of the Medcial Laboratory Science Program, and I'm in the College of Health Professions here in San Marcos, Texas. I was asked to speak to you today about some of my research interest, and it is an honor to join you in this podcast. So just a little background. I started off as an infectious disease specialist. So my degrees by training are microbiology. That's my bachelor's degree. My master's degree was in virology, the study of viruses. And ultimately, my PhD is in public health and adult learning. So that PhD allowed me to combine both my wet lab experience with public health focus, so that now I often can do both quantitative studies. I can also do qualitative studies, and then many times I'll do a combination of those, a mixed methods approach. So after my degrees, I'm going to talk a little bit about my career journey with respect to my research. So I really, the first decade of my career after I finished my master's degree is I ended up at the Texas Department of Health in Austin, Texas, and I was in the Bureau of Laboratories and later the Zoonosis Control Division. And this opened up an entirely new world to me, public health microbiology and infectious agents. And I spent that decade working in virus isolation, which is the isolation of all viral agents that are typically infecting humans. And then eventually I was in the rabies arbovirus laboratory, which is working specifically with the dangerous and deadly rabies virus, as well as other vector-borne arboviruses. You might know arboviruses nowadays from the words of things like malaria, dengue, yellow fever, Zika, chikungunya. These are all transmitted by mosquitoes as a vector. So that's what I did for 10 years. And so I was on the bench and I learned all about the world of diagnostics. So my background is medical laboratory science. That's where I'm at right now as the chair. And everything we do has to do with what is it that causes a particular human condition, whether it's an infectious disease, which is my area, or perhaps it's an inherited disorder or a chronic infection like diabetes. I'm sorry, not a chronic infection, a chronic condition like diabetes, or perhaps something like malaria that we mentioned earlier, or anemia, or sickle cell anemia, or others, just anything that can be diagnosed out of the human body is what medical lab scientists do. As I mentioned, my particular slant is infectious diseases. And so while I was working at the Department of Health, very fortunate, in the right place at the right time, I got asked to move into a position that was a hybrid position between the laboratory, the rabies laboratory, as well as Zoonosis Control Division. So I had a new title at that time called Molecular Epidemiologist. And I was on the inaugural team. This was like in 1994. I was on the inaugural oral rabies vaccine program team. We partnered with the Ministry of Natural Resources out of Ontario, Canada, with the Centers for Disease Control in Atlanta, with the Texas National Guard, with our own agency, the Department of Health, an APHIS and USDA, and many others that came together to try and eliminate canine rabies from Texas. So much of my research early in my career was applied. And so this team worked with the Canadians who had developed a recombinant rabies vaccine. That vaccine had a vaccinia virus carrier, which had a gene cut out, and we inserted the glycoprotein for rabies. And what that allowed is when we aerially distributed these vaccine doses across South Texas and West Central Texas, is wild animals that potentially could have rabies, like coyotes and fox and other animals, would eat that bait. Think of a small square dog food bait that had a vaccine liquid sachet inside of it. And so when they bit into that vaccine bait, it would cover their tonsils with this liquid vaccinia virus, which would create an infection, if you will, that was non-pathogenic, but it would express that rabies glycoprotein. And so ultimately, we created a living immune barrier of animals in South Texas and in West Central Texas. And to date, after about 10 or 12 years of doing that, we started in 94. So we just passed our 30th year in 2024 of that program. We eliminated canine rabies in Texas. We have not had a case of canine rabies in over a decade and probably more like 15 or 16 years now. So I always tell people it's one of the most amazing things that I think about, that I got to participate in that program, because I think it's one of the most globally successful public health, kind of One Health programs that you see as a model. It's being used now in the U.S. for raccoon rabies up and down the eastern seaboard. It's also used for skunk rabies in different parts of the U.S. Likewise, we're using it in other countries depending on their need. What was cool about this time period is during that time I got to train at the Centers for Disease Control for 2 different stints, and I literally brought in, back then it was new, now it's everybody's common language, but I brought in this brand new PCR technology. So the polymerase chain reaction, I had to use a reverse transcriptase PCR because rabies is an RNA virus and you have to create cDNA. And what we did is we created universal primers that would amplify any rabies variant. So rabies has a variety of variants like bat rabies strains and skunk strains and canine strains and what have you. And then we would do a restriction digest and ultimately sequencing to determine which variant we had. So not only were we doing the traditional kind of antibody, antigen, fluorescent antibody testing, which is the gold standard to figure out if an animal was positive or not, now I was tasked and successfully created, along with CDC help, this ability to type the exact variant of rabies virus we had. And we needed to know that because we needed to know where to place the baits. So again, this was kind of applied research. It was a public health campaign. I ended up creating, with help again, the regional reference rabies typing laboratory, which services still the entire US for typing rabies isolates, which variant that virus is, and sometimes globally, which strains we might be working with. Just one of the most amazing times of my life and career. I still work in that area. I still write and publish. I've written a book on rabies diagnostics and the oral rabies vaccine program, as well as human rabies issues. It's really about clinical considerations for pathologists and physicians to understand what might be happening with a human being that might have a known case of rabies, or what to do if they suspect they've been bitten by an animal that might have rabies. The proper vaccination. You can be vaccinated and save lives. I always remind people that rabies is a fascinating and diabolical virus that 100% of the time, mostly, I mean, it approaches 100%, will kill you, the mortality rate, but it's also 100% preventable with the rabies vaccine. So that's the good news behind it, is you can prevent it. But that ongoing effort in rabies and other viral pathogens, I also was part of the rapid response team where we went out and we did hantavirus investigations. You might have heard recently about hantavirus from the actor Gene Hackman and his wife in Arizona, in New Mexico. It's also found in Arizona and in the southwest part of Texas. Hantavirus is kind of spread around the US in different areas, and it's transmitted from rodent droppings, other types of rodents and mice that can excrete it in the environment. And then if you inhale it or you obtain it through some other route, you can come down with hantavirus. It has about a 20 to 30% mortality rate if you don't have proper healthcare types of procedures going on. So it's in the news again, along with measles and along with influenza and other agents that I consistently worked with during that time period. And plague, Yersinia pestis is also something you see. just a variety of illnesses. So again, this is how I kind of cut my teeth in the first decade of my career, working with the CDC, with the Department of Health in Austin. And at the time, I started adjuncting at Austin Community College because I love teaching microbiology. And then in 2001, I had the opportunity to come back to Texas State at the request of a former mentor, Dr. Bob McLean, who was in the microbiology department, and he was on sabbatical. So I came back and taught microbiology. And while I was here, I learned all about from Bob and Dr. Gary Aaron, another one of my master's degree mentors, that there was a position here in the Medcial Lab Science Program for a really an infectious disease and molecular diagnostics specialist. And so I threw my hat in the ring, never thinking in my life I would become a professor. And I got the job in 2002, and I've been here ever since. And so once I transitioned to Texas State, I've always worked with rabies. I continually kind of work with colleagues in that with respect to human cases and animal cases and writing and publishing. But because we didn't have a level 3, level 4 laboratory at the time, I needed to transition my work to something I could work with, more of a level 2 agent. So I'd always been kind of fascinated and wanted to work with antimicrobial resistant pathogens. So I switched to looking at methicillin resistant Staphylococcus aureus, aka MRSA. You might know about this pathogen if you've ever had a simple staph infection, kind of a skin infection. But at the time, these were becoming, and this was in the early 2000s and late 90s, MRSA was a new and scary pathogen because it wasn't responding to typical beta-lactam antibiotics. And so this is kind of the beginning, probably prior to that, but really kind of the heyday of antibiotic resistant pathogens. And now we know it's a global problem. We have many different pathogens that do not respond to all types of antibiotics. So it's really critical that we understand not only the identity and know when someone is positive with perhaps an MRSA infection, but what strain it is, what type of bacteria it is, and then the all-important susceptibility efforts of which antibiotics may still be useful and how to therapeutically treat that infection so that you can kind of hold that infection to a particular area. So that's what I did. When I transitioned in, I started doing my typical assistant professor work, working on my tenure track. I set up a lab here in the College of Health Professions. I got space for kind of a molecular laboratory here on the third floor of Encino Hall, and really started working in that area. And over the next 2 decades, kind of built my research efforts both in MRSA, but also now looking at infection prevention as a role, looking at healthcare associated infections, HAIs, really across all pathogens, but still with kind of a focus on MRSA. And I've done dozens and dozens of studies with undergraduate students and other colleagues here on campus where we've looked in the environment for MRSA. So a lot of the work I've done has not only been the pure microbiology around how to identify MRSA, but how to look at different environments. And this is where, as I kind of, the first 10 or 12 years of my career here, I was doing studies in different settings. So we did a study in dormitories. We did a study in athletic facilities. We did a study in physical therapy settings. We've looked at animals because MRSA can end up in animals. And just a lot of different settings. And we published those studies and presented those studies at different state and national programs with student co-authors and sometimes lead authors, which has been a very gratifying part of my career. But around 2006, I decided, I needed a PhD. I really needed to go back and pick up that doctoral degree so that I could maximize my efforts. And so I did that. That's when I got my public health and adult learning degree here in the College of Education at Texas State, and really did bridge, kind of became a hybrid researcher between kind of that laboratory environment as well as the public health environment, and really started doing different types of projects. So my dissertation, my PhD, was actually looking at individuals who had survived an MRSA diagnosis. By the way, this was personal for me because my father has dealt with MRSA over his lifetime. He's still hanging on. He's 83, and he still occasionally deals with an immersive flare-up. We think from a knee replacement, and so he is probably colonized with MRSA, and it pops up every once in a while. So it was personal for me. And so this study looked at about 20 or 30 roughly individuals who had survived it. But what I wanted to know, and I did both a logistic regression analysis to look for risk factors as well as personal interviews for kind of a thematic understanding of what these people needed to know, what they knew, what they needed to know, if you will, early understanding of science communication around health literacy. What do people need to know about an antibiotic resistant pathogen? And what do they need to know about the research and the testing? And what questions do they need to ask about these types of infections? And so this again was really a work of passion for me, just like zoonotic infections like rabies became. And so that's where I've been working in that space as well now. I've done a ton of work across that spectrum with different populations. We have also, as I mentioned, ventured into infection prevention efforts. I now work on several advisory boards around the country and globally as a global fellow, where we are looking at how people in environmental surfaces, these are the people that clean and sterilize and disinfect healthcare environments like hospitals, but also long-term care like nursing care and dialysis, as well as community settings like prisons, homeless shelters, anywhere where MRSA or other pathogens might inhabit, and even looking at how surfaces might influence colonization and infection transmission within a building. I often tell people that hospitals and buildings and other places can be a living environment because you can't always see a microbe, whether it's a virus or a bacterium or even a fungal agent. They're typically microscopic. We don't walk around with microscopic eyes. And so we have to have better toolkits on how to environmentally sample those environments, on predicting what types of building materials and building surfaces might be more antimicrobial, in other words, helping to prevent biofilm and other types of colonization practices by things like Staphylococcus aureus or other nasty bacteria like Pseudomonas aeruginosa. And so my focus, has become really both in the latter parts of my career here as a researcher. I'm still doing those types of things, both in the laboratory and across different types of qualitative surveys and other types of efforts. But I'm also, and really enjoying this, impacting policy, impacting how we talk about, how we educate people around these types of topics. And COVID, the pandemic, also helped influence part of this in my career because once that happened, it's one of the I am the only credentialed specialist in virology here at Texas State University. Our past president asked me to help with answering media questions, helping on campus, our former medical director with creating safe environments to teach in and how to conduct research. So I helped with pivoting to an online kind of educational model, which was at the time unheard of in healthcare and elsewhere. So that was a very tiring and frustrating, and yet one of the most exciting professional times of my life because I got to help make a difference, I think, in those areas. And because of that, now I work globally and just really excited and proud to be a three-time alum of Texas State University. I'm so happy that I get to continue to work here and mentor students and work with colleagues. We have great leadership, our new president, our new research team, our overall team from the provost office down has really enabled us to, conduct, as our former provost used to say, research with relevance, really where the rubber hits the road. How do we impact people's lives? So we are about creating research opportunities for undergraduates, for graduates. We're about looking at new and exciting degrees that allow us to turn out young people and old other people that are excited about opportunities in research, really across any area, from the biological sciences to the STEM sciences to the social sciences to the agricultural sciences, really anything that can help Texans improve the workforce, improve the quality of life, and ultimately improve healthcare and public health. So I thank you again for allowing me to join you. I hope that you'll get a chance to visit Texas State, and perhaps one day you'll end up in my program, Medcial Laboratory Science Program here in the College of Health Professions at Texas State. So thank you very much, and we'll see you down the road.
Biomed SA accomplishes its mission by supporting the companies and organizations already here, catalyzing actions for growth that benefit the entire community, and promoting the region and its assets. If you are seeking connections to resources or want to increase your company's visibility in this market, Biomed SA can help. To learn more about Biomed SA, the life sciences in the San Antonio region, or to access additional podcasts, visit biomedsa.org.